It's honestly a great honor to be invited here. It's absolutely marvelous, I think. So thank you very much once again. Well, I am, as you heard, from Gothenburg, which is the second city of Sweden. This is the symbol of our football team. We'll win this year, I hope. We came second place last year. Anyhow, we have about 800,000 citizens, and my hospital is called the Queen Silvia Children's Hospital, and it's 1 out of 4 pediatric surgery wards in Sweden. And we have an uptake of about 2.5 million people. As you heard, Professor Lusty said, mentioned Dr. Hythe and Dr. Rickham, and I have to mention Lars-Göran Friberg because this is my teacher who introduced me to esophageal atresia, and I think he's worth mentioning. Oh, sorry. So, as you have heard about the different types of esophageal atresia, this is the most normal classification according to Gross, and you see the type here in the middle is the most common esophageal atresia. And as you also heard, it's about 1 in 3,500 newborn children that has this malformation, which means that in Gothenburg we have about 8 to 10 cases every year. The interest of this made me write this little book, which is my thesis. I'll put it on the raffles table as a consolation prize for anyone who wants to look through it. It's no problem.
Is it possible for us to get a copy of that?
You can find it on the internet, actually, and I think that you can find the address in here. So please do if you want to.
I think we can email that out from TOFS if it would make it easier.
Yes, please.
Anyhow, why did I do this? I did it because I wanted to get more knowledge and understanding of esophageal atresia and to, of course, describe the occurrence of esophageal and respiratory symptoms, and also to investigate the prevalence of respiratory and esophageal dysfunction. And hopefully it would be at least a bit of a help to help me formulate guidelines. So between 1968 and 1983, there were 110 children born and operated on for esophageal atresia in Gothenburg. Out of these, there were, when I did my study, 80 survivors. And this is just a flow chart of the study. You can see from the beginning 110 patients, and the different parts of the study had different numbers of patients involved. And I divided my study into 2 parts, you can say. The first part was with questionnaires regarding esophageal or pulmonary symptoms. And the second part was the functional tests on the lungs or the esophagus. And as you all know, there are many problems when you have esophageal atresia, both as a child but also as an adult. And I think that at least before, the tendency to underestimate these problems among the pediatric surgeons and others have been great. So the first part of my study was looking into the questionnaire for the esophageal symptoms, and especially with focus on dysphagia. I'll come to why later. And it was because dysphagia is, no one can tell you what dysphagia is exactly. So when you look in the literature, you get many different numbers of how common it is. But by introducing a system with numbers, I could measure the dysphagia more quantitatively. And by doing that, I wanted to investigate if there was any possible correlations between dysphagia and other factors among the people with esophageal atresia. And I went through all the hospital records of the patients, and they got, as you see, 3 different questionnaires. I show you them later. And I also asked about their height, weight, medication, other diseases, smoking habits, and so on. This is the questionnaire which I used for the dysphagia. It has been used before on other patients. And as you can see, it's 9 different types of food, which gives you a total score as a max of 45. And if you have 45, that's the severest type of dysphagia, you can see. Then I went on to another questionnaire regarding the gastroesophageal reflux disease symptoms. And this is on a 1-week time frame to see how much problems they had during that week. And I focused, of course, on heartburn and regurgitation, which are the most common symptoms when it comes to gastroesophageal reflux. And to study the quality of life, I used the most commonly used questionnaire, which is called SF36, which contains of 36 questions in different aspects concerning the quality of life, and is divided into 2 bigger parts. That one is looking at the physical health, and the other on the mental health. In order to get a more homogeneous study group, meaning that I didn't have to think about other confounders, because there are many different types of esophageal atresia, and they can give different problems, of course, and some of them don't give any problems at all. But then I managed to look at the most common group, which is this with the atresia, proximal atresia and a fistula to the trachea. And that was 63 patients, and actually it was 91% of the total group. So what were my results? Well, I found that as many as 57% had dysphagia to some account. And this might be obvious, but the higher viscosity and solidity, the more complaints and the higher score. But it had to be shown. But I didn't find any correlation between early risk factors, for example, time of dilatations, fundoplication, and so on, or patient's demography and dysphagia. What I found was I couldn't help looking into the gross type A, meaning this is usually the long gap esophageal atresias without any fistula. And we know that they have much more problem. And I wanted to test if this score could sort out the problems between these 2 groups. And it did quite well, because it was a great difference in dysphagia between this group and the big group that I looked at. And I also noticed that there was actually a correlation between dysphagia and one of the gastroesophageal reflux disease components, namely regurgitation. In the group as whole, 32% had heartburn and 40% had regurgitation. So you see, those symptoms are also very common. I thought that this was actually very nice, because when I compared the quality of life to a randomly selected age and sex matched group, it was actually comparable and as good as that group. And I couldn't either see any correlation between the patients with dysphagia, more or less, and the quality of life. So my conclusion was, of course, that dysphagia is very common. And by using this score, I thought that it would be useful for me in the evaluation of the dysphagia. And maybe the score can be part of a more standardized definition of dysphagia in the future. The second questionnaire was regarding the symptoms from the lungs. And here I also wanted to describe the occurrence of respiratory symptoms in adulthood. And it was the same cohort as in the first study, but now I included all the patients, actually. And this questionnaire regarding the respiratory diseases symptoms, it was also about rhinitis and possible risk factors. And the questionnaire was based on another question, on the same questionnaire that is used in a Swedish study that is very widely used internationally and looks on obstructive lung disease. And as a control group, using the same questions and done in the same time period, I had about 5,000 age and sex matched subjects from the same region. And I looked into different symptoms. The questionnaire contains 35 different questions, but there are some of them that are more common and appropriate to look into when you speak about esophageal atresia. And not surprisingly, of course, respiratory symptoms were much more common among the atresia patients. And I want to go back to Professor Losti again, who said that the former experience was that these symptoms became better when the patients grew. But our numbers couldn't show that because they were very, very common even among our adult patients. And one thing that also is known is that physician-diagnosed asthma and medication is much more common among patients with esophageal atresia. But no one knows why, and even if it's true, actually. Because the allergic rhinitis didn't differ between the groups, and neither did the heredity for asthma or allergic rhinitis. And we did not see any difference between smokers and ex-smokers. So in conclusion, I found a very high prevalence of respiratory symptoms. But I also found a high prevalence of doctors diagnosed asthma, despite the fact that there was no difference between the groups when it comes to allergic rhinitis or the heredity for asthma, which are known risk factors for asthma. Of course, you can't say if the asthma diagnosis is right or wrong when you just have a questionnaire study, but you have to go on with other investigations, which led me to the third part. And now I started to look at the functional tests on the patients. And I wanted to investigate the prevalence of airway dysfunction, and with a special focus on the peripheral airways, because this has never been done before. And I wanted to see if the dysfunction correlated to the symptoms, because we know that in the past there has been a bad correlation between what you find when you do your measurements and the symptoms. And I also wanted to look into if the asthma diagnosis seemed accurate. I started up with the same 63 patients, but for, I would say actually obvious reasons, 29 just wanted to participate because There were quite many examinations. I approached adult patients who hadn't been in contact with the healthcare for many, many years regarding their esophageal atresia. So I'm very grateful that as many as 29 wanted to be on this. And once again, I used the same questionnaire regarding the obstructive lung disease. And I did several different types of pulmonary function tests, looking on both the peripheral airways and the central airways. And then I also did some tests that are commonly used if you want to look further into the asthma diagnosis, that can show you if there is inflammation in the airways and so on. What's the peripheral airways? This is the bronchial tree, and it branches, as you can see, many times until it comes to the last alveoli down here. So, usually you say that the peripheral airways are the airways below the 8th branching, and then you have a diameter of about 2 millimeters in the airways. So this is me, not shaved, but is when I'm doing this multiple breath washout, which is specific for the peripheral airways, to look on the peripheral airways. As you saw from the first questionnaire, symptoms are very common, and actually only 6 patients, or 21%, didn't have any symptoms at all. These are the results from the different tests, and the one called MBW here is the one showing the peripheral airways. And you can see that as many as 17 patients, 61%, had some kind of disturbance in their peripheral airways. And this would have been missed if we just used the commonly used investigations when you look at the airways. And the commonly used investigations are that what you call spirometry, inhale, exhale. And of course, that was also affected on the patients. And 6 of them had what you usually can see when you have asthma, actually. On the bottom line, we did one thing called whole body plethysmography, and it shows if you have a reduction of your total lung capacity. And we saw that 32% had that. One explanation for that can be, of course, post-operative strictures from the rib, between the ribs and the rib cage. So, actually, only 5 patients displayed normal values in these parameters. But even though we introduced this multiple breath washout, we could not see any correlation between the symptoms and the pulmonary function tests. And you may ask why. Yes, one of the answers is that even among those patients that didn't fall out on the function tests, there were many symptoms. So that was a problem. These are the inflammatory tests that were done, as I told you, that are sometimes correlated to asthma, and we could find that they were quite raised too. But even though we found the different things on the lungs and these tests, the patients with doctor-diagnosed asthma did not differ from the rest in either symptoms or any of the tests which we did, actually. So in conclusion, we found a high prevalence of respiratory morbidity and impaired lung function. And the impaired lung function was actually mainly peripheral. And respiratory symptoms are very common but can't be explained by the pulmonary function tests. But as you could see, caution is advised when it comes to giving the patient the diagnosis of asthma. The last part was, of course, then about the esophagus. And we wanted to use this pH multi-channel intraluminal impedance, which is a technique that you don't just look at the acidity of the esophagus, of the reflux, but also can see if there's content that's going up that's not just acidic, or maybe just weakly acidic or weakly alkaline. Because usually, historically, we have just been using the pH monitoring for these patients, and then you just get the acidic reflux, but you miss the rest of the reflux, which might also cause damage or symptoms. We know that now. This is how it looks. Many of you have probably done this, or at least pH. So it's used in the same way. You put it in the nose and you walk with it for 24 hours to register how it looks. And the gastroesophageal reflux content can be divided into acidic with a pH below 4, or weakly acidic with a pH between 4 and 7, or non-acidic with a pH above 7. And the aim was to introduce this new method to evaluate the prevalence of gastroesophageal reflux, irrespectively, of course, of the pH, and to see if we could make any associations between the esophageal symptoms. And we also wanted to see if this method could help us improve the identification of risk factors for changes in the esophageal histology. It was the same poor patients that with the pulmonary function tests. They were amazing that they wanted to do this too, I must say. But some of them fell out, as you will see. We used the same questionnaires as we used in the previous study. We introduced this pH multi-channel intraluminal impedance, and we also used manometry, which shows how the contractions of the esophagus is. And we did a gastroscopy with pH. So we found out, as we knew from before, that both heartburn and regurgitation is common, and as many as 48% had any of those both. And in this group, actually, as many as 76% had dysphagia. Of course, we compared this group to the group that didn't want to participate, and at least statistically, we couldn't find any difference between the two groups. 15 wanted to do this technique, and five of the patients had a pathologic acidic reflux, which would have been caught if you just did your pH standard test. But as many as 10 patients had a reflux with a pH above 4, and these would have been missed if you had done the old technique, actually. And 11 subjects had any pathological reflux at all. 19 patients performed manometry, and we could see that the esophagus was quite disturbed because there was a high presence of both bad contractions and with a bad peristalsis. And we found that there was a correlation between weak contractions in the distal esophagus and non-propagating peristalsis. LES is the lower esophageal sphincter, which is a very important mechanism to prevent gastroesophageal reflux. We found that the resting pressure there was quite good in most of the patients. And why is that interesting? I'll show you. With the eye, that 10 of them had macroscopic inflammation, but another 4 actually were found to have a microscopic inflammation, which would have been missed if we just looked at it and said, oh, this is nothing. So this shows the importance of also taking samples when you're there. And as you can see, 2 had Barrett's esophagus. I think you've heard of that. Mm-hmm. And that's quite many among 24. And now I come back to this lower esophageal sphincter because, as I told you before, the resting pressure in the most of the patient was quite good, but the function in the sphincter was bad because 14 out of 24 patients had an incompetence that was respiratory correlated, meaning that when they took a deep breath, the lower esophageal sphincter opened and reflux could get up, actually. And in 7 patients, the sphincter actually was open.
Where is that? That's the one at the bottom of something?
No, it's before it enters.
To the top.
Before it enters the ventricle. That's the mechanism that prevents the stomach.
Cool.
We didn't find any statistically significant correlation between gastroesophageal reflux symptoms and this measurement. But we found that both the dysphagia score, or actually dysphagia problems, and esophagitis correlated in some aspects to the results that we found. And I say in some aspects, meaning that it was with patients that had reflux above pH 4, which would have been missed if we didn't do this method. We didn't see any correlation between dysphagia and manometry, which some have stated that there is. And this can be, of course, because of the quite small number of patients. But we also saw that this bad functioning esophageal sphincter made it easier to get acid reflux. So in conclusion, we found a high prevalence of gastroesophageal reflux, and this new method added knowledge which would have been missed actually, namely the correlation to dysphagia and esophagitis. So in summary, what did I find? Yeah, I found that both esophageal and respiratory morbidity remains in adulthood and is sometimes quite a big problem. And the impaired pulmonary function, especially peripheral, appears to be more pronounced than previously described. The classic asthma diagnosis appears to be difficult to diagnose. And this new method seems to improve at least some of our understanding when it comes to esophageal symptoms and in identifying risk factors. So for the future, these 2 things are some of the most important that we have to work with now. We need to have a standardized follow-up on both the children and the adults. We need to find adult gastroenterologists, surgeons, whatever, but people that are interested and dedicated in these patients in the same way as the cardiologist surgeons have found natural ways to yes.
I feel that the paediatric doctors have got to give the doctors in the adults more information, because it's never a condition that starts in for adults, so they're really working blind.
Yeah.
The ones that do see the adults. No, it has to follow through.
In Gothenburg, I've had contact with both upper GI surgeons and gastroenterologists, and they've been involved in this study. And I tried to get them more interested and tried to get them to follow up, but it's not that easy actually.
But it's not a condition that ever starts off when
No.
you're 35, so it's,
No.
what is out there is very little. It's they've got to liaise.
This is my hospital, up in the left. This is how it looks today. This is how it's going to look 2020. I hope. Thank you very much.
A few questions. How many of your patients had fundoplication done?
Only 5. Yeah.
And they had symptoms?
Yeah, but I couldn't rule them out from the rest. They didn't have more or less symptoms than the others. But we have, for some reasons, we have not done that many fundoplications in Gothenburg, and we know that when we do fundoplications on the smaller the child, the bigger the risk for failure. So we try to hold them as much as we can.
You say that the LES in people with EA is a bit random and opens and closes. I'm now completely judge-fed, and I have to empty my stomach because my reflux became so severe. I had a fundoplication when I was 18, but it failed and caused nerve damage. But would you say, obviously, no medication worked for me. Is there any other routes we could try with regards to stopping the reflux?
Well, I haven't done. Have you done this?
Strategy?
Yeah.
No. The strategy procedure, is that what you're referring to, the strategy?
No, the Bianchi that.
No, just, no. Matthew can comment.
It's very.
You mean the Bianchi Esophageal
I think that's
Association?
Yeah.
And I've done a few of those, but never in this situation. I've been terribly wary about doing it on esophageal atresia because we've been taking the vascular supply to the lower esophagus, which is probably where it's getting its blood from. I think it could potentially be disastrous.
Okay.
Maybe not.
I'm really wary
The
about
question,
it.
the answer is it's tough. I don't have an answer.
Okay. And with like the non-acidic reflux, where would you say that's coming from?
From the bile, maybe.
Is from like your judge and upwards?
Yeah.
Okay, that makes sense.
Another question?
At this point, I got the impression that there was an implication that there was a misdiagnosis of asthma.
Yes.
Yeah? Is it a problem if you're treated for asthma when your complications are from another source? I mean, we get Montelukast, we get salbutamol, saline, the inhaler, steroid, because she's got tracheotox. So if she gets a cold, they give her a steroid to open up her airways, and then everything's fine again. But it can be a problem because there's a risk that her trachea goes up.
I would say that if it helps, if it actually helps, there shouldn't be any problem. But the problem is that I think that many patients have the medications without getting any help from them. They just keep on taking them for no reason at all, actually. But of course, if it helps, but the problem is if you have many different medications, how do you know which of them helps best? Because we also looked into our children between 0 and 7 years old, and their main problem from the airways was from the central or higher airways, and of course those patients won't be helped from salbutamol and so on, but the most important thing for them is maybe saline inhalations and physiotherapy, actually.
Okay, just time for maybe one or two quickly. Yeah, or maybe we've got a few more.
What impact does diet have? So, because I've been I've been in a hospital my whole life, and hardly any doctors have ever heard of what I have. I don't have an esophagus, I'm slightly different, and they say, oh, you've got IBS, oh, you've got celiac disease. I don't have any of that, but they just scratch their head because they don't know. It's a bit of an unknown quantity, and they say, well, if you're having that much reflux, you must be eating the wrong stuff and eating really late at night. And I said, I can't eat late at night, I can't eat past about 6 p.m. And if I do eat certain foods, I just cough because it must be greasy, or do you know, that sort of thing. And they don't give you any. There's a FODMAPs diet as well. Yeah. So they don't, but they just say, oh, well, get on with it, you know. And I'm like, well, that's really helpful, but they don't. Yeah, I didn't know if there was any sort of. I mean,
special.
Is there food I should be avoiding? Is there food I should be eating? Should I eat food at a certain time? What should I be doing?
I think that you can't solve it with just the food regime, because it's not just a simple reflux without anything else. Otherwise, you should use the same instructions that you usually give to patients with reflux. Don't eat too late, don't eat too much at a time, don't eat too strong food, don't drink alcohol.
We've got a general question and answer session this afternoon at, what time was it, John? 3:45?
4:45, yeah.
4:45. I'm just wondering if we've got enough of our... You will still be here. I don't know who else will still be here, maybe to... And maybe we can just follow up, you know, with a broader audience on that topic. Yes?
Yeah, can I just suggest that we have some more with adults in the future, because some of us here are pretty desperate with the press conference.
Yeah, and there is there's an informal gathering for adults at the lunch break as well. But
yeah,
we'll take that on board.
Can I just put silent reflux on the agenda and what it means to... what it means, really.
Well, okay, for this afternoon, yeah, we can do that for reflux this afternoon. Any more before I pass on to Abby? Okay, well, thank you ever so much for it. Thank you, everybody.